Good morning, I'm Dr. Memeo, I'm a general surgeon and I work here in Strasbourg in a hepatobiliary unit. So we will speak today about hepatocellular carcinoma. Hepatocellular carcinoma represents the fifth most common cancer in the world with third cause of mortality for cancer, and it represents 75% of cancer of the liver. Concerning the geographic distribution of the cancer, we found that it is more endemic in some zones in which hepatitis C and hepatitis B are most common, as in Asia and in Africa. It represents a pathology that is characteristic most of male in 75% of cases, with diffusion in about 90% of cases on pathological liver in presence of fibrosis and cirrhosis. The distribution varies from Europe to North America and Asia, but globally we can find about 40% of cases of HEV pathology on the liver, with 25% of cases of hepatitis B virus present in the patient, and with the spreading cause of non-alcoholic steatohepatitis in about 10% of patients. We have three main aspects. In macroscopical aspect, we can find nodular form, who usually is present as dysplastic nodule with HCC foci in some nodule of less than 2 cm who are circumscribed and capsuled, and it will be present also in lesion of a bigger size. Infiltrative form is in 45% of patients. We found non-circumscribed nodule, not encapsulated, with a diffusion to hepatic parenchyma. It represents a more aggressive form of hepatocellular carcinoma. The rest of macroscopical form is the multifocal form, in which about 20% of patients nodules are spread in the parenchyma of the liver. One of the most important characteristics of the hepatocellular carcinoma is the nodules, the satellite nodule. Satellite nodule defined as some nodules that are present in less than 2 cm from primary tumor. This is probably found in 6 to 25% of cases. If a nodule is found at more than 2 cm, it's considered as a new hepatocellular carcinoma. Concerning the macro and micro vascular invasion of the tumor, it's present in 50% of portal branches and 10% of hepatic vein. It has also an invasion in the biliary tree, about in 5% of cases. Concerning the epidemiology, we can find the treatment in the left part of the slide. Only 22% of patients have a curative treatment with resection, radiofrequency, or transplantation. The rest of patients are in palliative or chemotherapy. On the left, in the right part of the slide, we have the overall survival in function of treatment. The best treatment for hepatocellular carcinoma remains the transplantation, followed by hepatic resection, radiofrequency, and chemioembolization and the chemotherapy compared to palliative treatment. Liver transplant represents the best treatment, as we told before, for hepatocellular carcinoma, but we have to consider the problem of indication to transplantation, and we will see it later, and at the same time the unavailability of graft. This is one of the most important papers on the treatment and management of hepatocellular carcinoma. It was written in 2005 by the Barcelona group. It shows us the different kind of treatment of hepatocellular carcinoma in function of the number of nodules, the size of nodules, and the performance status of the patient and the child pug. As we know, child pug can be divided in three classes: child pug A, B, and C. This is a classification in function of the gravity of hepatic function. Child A are the best patients compared to child C. And in the child classification, we have the bilirubin, the ENR, the albumin, the encephalopathy, and the presence of ascites. Concerning surgical resection, it represents one of the most diffuse treatments for hepatocellular carcinoma. There are some limits as an indication that could be respected, but the aim of hepatic resection is to have a complete resection of the tumor with the resection of tumor-bearing portal territory. It means it's very important to resect the nodule and all the territory that receive the inflow by the portal vein. It will be responsible for the inflow of the tumor. It means that if you have a nodule in segment Cis, it's very important to resect not only the nodule but all the segment Cis. In this concept is included the concept of satellite nodule that usually are less than 2 cm from the main nodule, and they are usually resected if we resect all the entire segment. It's very important the concept of sufficient future remnant liver. It means that we have to leave a part of the liver that is sufficient to guarantee a normal hepatic function. It's mandatory to have an evaluation preoperatively of the function of the liver. This evaluation could be done by the volumetry, by the hepatic test, and by the indocyanine green test. That is a test that measures the possibility of the liver to metabolize the indocyanine green. There are some contraindications. It could be oncological in presence of extrahepatic disease, of macroscopic vascular invasion of multiple bilobar nodule, or some contraindications that are linked to the hepatic function. It means in some patients that have child PUG B or C with a not so good hepatic function, resection is contraindicated. Indocyanine green value of more than 15% associated to major hepatectomy represent a contraindication, has future remnant livers of less than 40%. Active hepatitis with transaminases 2 times augmented compared to the normal value are a contraindication, as is considered contraindication the portal hypertension with ascites, collateral circulation, and esophageal varices of grade 2 and 3. In this movie, we see a CT scan with the presence of 3 nodules in the liver. This represents the part of the preoperative study of the patient that also is associated often to a 3D reconstruction that shows us the localization of the nodule in relation with the vessel and bile duct in the patient. It allows donc to have the volumetry of the segment that we have to resect and the possibility to evaluate the future remnant liver. We are calculating in this video the volume of the segment to comprehend which one could be resected and which is the value of future remnant liver. It's very important to analyze also the vascular variation that could be important during the resection. We can have major resection if we resect more than 3 segments. In child PUG A, indocyanine green value normal, absence of varices or esophageal varices, more than 100,000 platelets, and normal transaminase acid in the presence of future remnant liver. So with this condition, we can have a major resection with more than 3 segments. In case of child PUG A or indocyanine green with an abnormal value or varices esophageal varices, we can have a minor hepatic resection that could be tolerated by the patient. If we have a perturbation of the hepatic function and the quality of parenchyma is not so good to allow a minor resection, we can have a subsegmentectomy or a wedge resection. The role of surgery is important because we can have 3 kinds of axes. It could be considered in intention to treat. It means resection as treatment of hepatocellular carcinoma. In case of recurrence, we can have transplantation, even if 60% of patients had recurrence and out of transplantability criteria. It can be considered as a bridge treatment transplantation in patients that are inserted on waiting list. It will avoid the progression of tumor waiting for the transplantation. And in this part, it's very important the role of laparoscopic surgery. Selection of patients for transplantation could be done also with resection. We will have after the resection the specimen with the pathological finding that can indicate as the best patient to treat with the transplantation and to optimize the graft, choosing the best candidate. This paper, written in 2014, we have the confirmation that laparoscopic surgery is one of the best treatments for hepatocellular carcinoma and can be proposed as the first treatment for resectable patients. In this video, we see a short movie about a segmentectomy for an hepatocellular carcinoma in segment 5. With the fusion of image and Doppler ultrasound, we see the vascular wrapper of the lesion. The aim of this resection should be to resect all the territory that he received the inflow for the portal vein of segment 5 in a way to resect the nodule and the satellite nodule that usually are in the segment in which the tumor is. If we consider the surgical resection, in case of single nodule with the absence of portal hypertension in a child-eye patient, we can achieve result at 5 years with 75% of patients. We have a good survival. It represents a very good result compared and associated to the result of liver transplantation. What are the alternatives to hepatic resection in case of non-transplantable patient and non-resecable patient? We have radiofrequency thermoablation, percutaneous alcoholization of the tumor, and transarterial chemioembolization or radioembolization. So radiofrequency represents one of the alternative treatments to resection and transplantation. It is a treatment of the nodule who is treated by radiofrequency with this probe that are inserted in the nodule under ultrasound guide and who provide the thermic treatment of the zoom of the lesion. There are some studies that compare radiofrequency to surgery, and they show that there are results that are comparable in selected patients with the same rate of survival at 5 years. So you see in this picture the possibility to treat on radiofrequency also in laparoscopy using the ultrasound, the perioperative ultrasound that will guide the treatment. Another option is transarterial chemioembolization. It utilizes the concept that hepatocellular carcinoma is vascularized 95% by arterial flow and 5% on portal flow. It is the opposite of normal liver, in which the most part of the flow is the portal flow with 75% of inflow and 25% of arterial inflow. So in this way we will, under radiological control, arrive to identify the zone of the liver in which we have the lesion, and we treat it with the injection of some chemotherapy. The results are encouraged, less important than the one compared to resection and radiofrequency, but they could be used also as a bridge treatment for liver transplantation. Now it's ongoing the possibility to treat the hepatocellular carcinoma in unresectable and untreatable patients with sorafenib, who represent the chemotherapy of this cancer, that guarantees some results that are encouraging with the difference in terms of overall survival, disease-free survival, but in practice it's a very expensive treatment for only 12 weeks of extra survival in median. Concerning liver transplantation, he had 50 years old history, starting with the first liver transplant in 1963 when we have 0% of survival at 3 months, up to 1996 in which the Milan criteria were established when we have a 75% of overall survival in patients that were transplanted. So in France and all over the world, the situation is a little bit complex in a way that it will be even more answer of transplant in present of even less graft. So in the history of liver transplantation, different criteria were established. Every team established some criteria with different results, and the three main important papers and criteria that establish the level and the selection of patients to achieve good results are the Milan criteria that were established by Mazzaferro in 1996, who chosen a single nodule of less than 5 cm or 2 or 3 nodules, none exceeding 3 cm, without vascular invasion and extrahepatic spread. In this case, we can achieve a 5-year overall survival in 75% of cases. The team of San Francisco tried to extend this criteria in 2001 with including as transplantable criteria one single nodule of less than 6.5 cm or 2 or 3 tumors non exceeding 4.5 cm with total tumor diameter of less than 1 cm, even in absence of vascular invasion or extrahepatic disease. And they show that also if they enlarge the criteria of transplantability, they have the same result as the Mazzaferro team. Mazzaferro also changed another time the criteria in 2009 and established that transplanted patient could be patient in which the number of tumors, more the diameter of larger tumors, are less than 7. These criteria are called the up to 7 criteria, and consider that also if he enlarged the transplantation criteria, he could achieve the 72% at 5 years. This image represents the rate of survival in function of the size of tumor and the number of tumor. Evidently, the more the tumor are big and the more they are, the less we have overall survival. In 2012, a very important study performed by Professor Devaux in Paris showed that there is a correlation with the level of alpha-fetoprotein, and he defined 3 criteria to select a better selection of patients. And these are the number of tumor, the tumor size, and the alpha-fetoprotein level. He showed in a simple table with a cutoff of 2, giving some score to each of these characteristics. And in patients that have a score of less or equal to 2, he can achieve a 5-year overall survival of 68%. And he showed the superiority to the criteria of Milan, showing a better survival in the group of in Milan criteria and the better survival group in the group without Milan criteria. It's very important to develop some concept of liver transplantation that will be used and analyzed. It will be the dropout concept, the downstaging concept, the bridge treatment, the recurrence, and the salvage transplantation. First of all, the dropout concept represents the possibility to going out of list for a patient. It means that one patient on day 0 is inscribed on transplantation list, but during the period in which he's waiting for transplant, the pathology the cancer grows and it goes out the criteria of transplantation. And we can see a global monthly dropout for all causes at 4% for hepatocellular carcinoma and 3% especially for the pathology. The bridge treatment is the treatment of hepatocellular carcinoma during a period on waiting list, impeding tumor progression. So we can control the pathology waiting for the transplantation with chemioembolization, alkalization, or radiofrequency, with a reduction of dropout of 10%. The downstaging is a resection of hepatocellular carcinoma that usually are out of criteria to allow inscription on waiting list, allowing them to enter in the transplantation criteria. In this paper of Gordon Weeks, he showed that the resection and the insertion due to the downstaging allow us to identify the pathological characteristic of the hepatocellular carcinoma and to have a preemptive inscription for patients with very aggressive pathology, and in patients with low risk of recurrence, a salvage transplantation only if the pathology have a recurrence. Another concept introduced by Cherki in 2009 is the salvage transplantation. Salvage transplantation is a liver transplantation in resected patient at the moment of recurrence. It means that we resect the patient instead of inscribing him directly on transplantation list, and we wait for the recurrence. And he showed that with this strategy, he can achieve a 10-year survival, about 50%, that is exceptional in case of resection for hepatocellular carcinoma. One of the most important problems is the recurrence for hepatocellular carcinoma. In this series published 2 years ago of 780 patients transplanted for hepatocellular carcinoma, we have recurrence in 15% of patients who underwent liver transplantation. 31% have a curative treatment by surgery or radiofrequency. 42% have chemioembolization or sorafenib, and 26% at best supportive care. And identified as factor of recurrence the alpha-fetoprotein on more than 100 and the early recurrence. So in conclusion, hepatocellular carcinoma is the 5th most common cancer in the world. We have several therapeutic options available, but only 25% of them are curative. Hepatic resection is feasible in selected patients following the Barcelona flowchart. Liver transplant rests the best option of cure for hepatocellular carcinoma. In case of non-resectability, non-transplantability, or recurrence, we can have radiofrequency, chemioembolization, and chemotherapy with sorafenib that represent an alternative treatment. Thanks.